right, we're recording to the cloud. I'm going to make you the host. All right. Okay. Now, in about 30 seconds, Jeanette, you can broadcast.
Okay.
Actually, you can go ahead and broadcast, and then we're just going to wait till 8 o'clock.
Okay.
Good morning, everyone, and welcome to the first QMS session. It's exactly 8 o'clock, and since this is our first session, we're going to give everybody about 1 extra minute before we start. So the webinar will begin in 1 minute. Good morning, everyone. This is Dr. Dan Milner, the Chief Medical Officer of the American Society for Clinical Pathology. And on behalf of myself and Dr. Tim Almakili and Dr. Emily Glenn from Pathologists Overseas, we'd like to welcome you to this Quality Management Systems course. This will be a 10-week course that runs every Tuesday and Thursday. In the introductory email that you received, there was a link to a landing page. If you do not receive an email telling you to register for each session, you can always go to that landing page in order to register for the sessions as they come up. However, you will need to register for each session in order to get the link for the unique webinar for each session. In the link that we send you each week before the session, not on the landing page, there will be the case attachment, which you should review prior to the course starting. So we would hope that when you get that email, you'll see the case, and then you'll be able to work through that and then join the webinar at the appropriate time. So just a reminder, you do need to register for each of the webinars every Tuesday and Thursday, and you should get a reminder email, but you can also do that from the landing page. Today, we're going to actually start with an introduction, and she will do a case as well from Dr. Jeanette Warner. I'm going to turn it over to her. She's from Emory University. She is a quality expert and does a lot of work with trainees at Emory on this topic. But I'm going to allow her to introduce herself and then take off. Go ahead, Jeanette.
Thank you, Dan, for the invitation, and thank you for the introduction. One of the things that I always like to tell people is that I have worked not only in the United States, where I am currently living. I live in Atlanta. Atlanta is if you think about the United States and you think about Florida, it's right up about Florida. That's where Georgia is, and that's where Atlanta is. So we're very close to the Florida little peninsula. But originally, I was brought up in Mexico, and I actually studied medicine in Mexico, then came to the US to do my pathology training, and then went back to Mexico and worked for 7 years at the National Cancer Institute in Mexico, and then came back to the United States and worked first at the Centers for Disease Control for the CDC, and then I'm currently working at Emory. With the ASCP, I've been doing several of these courses on quality, which have given me a lot of satisfaction. We've been doing them in Spanish because obviously I speak Spanish. So we've been doing it in Colombia, we've been doing it in El Salvador, we've been doing it in Paraguay. And I'm so excited that we're doing this course, the whole entire course for Africa. I think that's a wonderful opportunity that is happening. So without further ado, let's go on with the presentation. So let's see. Oh, then for some reason, this is not moving. Okay, the learning objectives. So I hope that at the end of this activity, this session, you all will be able to explain the importance of quality management system, and then list the quality management system essential elements, which you'll see there are 12 of them. Describe a little bit the history of the development of quality principles, and we're going to do a very short thing on ISO and CLSI standards, which will be touched later in much more detail. So when we think about quality in anatomic and clinical pathology, we have to be thinking about the entire situation, from the moment that the patient is bled or the sample is obtained, to taking that sample to the laboratory, to preparing that sample, to testing the sample, and then putting the results in a computer or in paper, and then whoever the physician is taking those results and telling them to the patient or acting on those for the patient. So when we think about the laboratory and all that it impacts, it really impacts the entire healthcare of patients. So the first question I have for you is, what would be the percent error that we should accept in the lab? I'm going to give you a few seconds to think about this question a little bit. Is it 0.001, 0.01, 0.1, or 1%? So if you think about it, 0.001 is one error in 1,000 opportunities. So that is a very, very high rate of error if one thinks about it. When we're thinking about Six Sigma, and you'll hear this term Six Sigma or Five Sigma or Three Sigma, you're going to be hearing those terms through the course. Having Six Sigma is having 3.4 errors per 1 million opportunities. So actually, of the question that I gave you, we should not even accept 0.001. We should even be better than that, because an error rate of 1% would mean that every day, if you think about it, there would be 3 bad landings in the airport in Paris, the Orly airport in Paris. And we hardly ever hear of so many bad landings. So how did the people in the airline industry ended up getting so good at not having errors? They used to have quite a number of errors if you look at that graph in the 70s, but then it really has dropped down to having almost no fatalities in the airline industry. So how did they do it? They do it because they have this big checklist that they've been using. And it's not that they are big, but they are really good at detecting if there's an error in any of the controls of that airplane or in any of the potential issues that the airplane can have. So they have this checklist, and they invented the concept of checklist. Then they also do a ton of training and development of all the people that are flying those airplanes, the pilot and the co-pilot. They go with lots and lots of training, and they have a lot of a quality management system that includes everything that we will be talking about with documentation and audits and staff competency. So they're constantly doing the things that we will be talking about in this course. And today is just the start, but this is all the things that you need to be thinking about. So essential to all aspects of healthcare are what the laboratory results are. We want them to be accurate, reproducible lab results. We want them to be available in a timely fashion. what if we do a report on a tumor of a patient, but we took so long to do that report that all of a sudden, instead of being available in 2 weeks, it's available in 3 months. And by the time it's available in 3 months, the patient is dead. Well, that wasn't really good or timely. So we really need to be have timely reporting so that it has an impact on the patient and it is available for the physicians to act on it. So the biggest problem is that laboratory errors cost a lot. They cost a lot in time, in personnel effort, and obviously the biggest thing is they end up costing in patient outcomes. So it's so important for people to realize that laboratory errors are extremely costly. And the last thing that we want is to have bad patient outcomes because we have lab errors. So people consider, or I guess we consider being ourselves laboratorians, that labs are the hidden treasure of the healthcare. We basically provide 94% of objective data in the medical record. When you look at the medical record, every single entry, say, of a CBC, how many white cells are in the blood, how many platelets, how many red cells, what's the size of the red cells, all those are objective data that are giving data points for the physician to act on. And we know that all those results that we're putting on the chart have an influence on what the clinicians are doing. And it's estimated that it is between 60 and 70% of the decisions are done obviously on how the patient or what the patient's complaining about, but also on what they see in the lab results. The lab results are integral of whatever clinical decision is done. They're also an important part of the practice guidelines. So they're about 37% are reported or are taken in consideration for any practice guideline. And they define a disease in 23% of the time. And this is by growing numbers, how the companion diagnostics are so important in defining diseases. So this is a little square thing that you are going to be seeing along through every single one of the presentations, because this little schematic has all the elements of the quality management system. Okay, so we always think of quality as the process control, the internal quality controls, external quality controls. That's what we are usually thinking about. But in reality, the quality management system includes everything. It includes how the laboratory is organized and what's the relationship of the laboratory to the administration, to the physicians. So that organizational structure is super important. The personnel, the people that are in the labs and their competency of the people, the equipment, what equipment you have, has it been validated? Do you have maintenance on the equipment? All the purchasing and inventory, do you have the reagents that you need to be able to produce results? Obviously, we talked a little bit about the process control, and there's going to be plenty of sessions on process control. How do we manage the information? How do we send out the information to our clinicians so that they can act on the patient results? So that information management is huge, whether you do it on paper or you do it in a computer. Documents and records is I always like the saying that if it hasn't been documented, it hasn't happened. So, you always think, okay, so if you may have done something, but if you didn't write down, I did this, it really, whoever comes next doesn't know that you did it, and they may do it again. So if you don't document, things never happen. So it's important that documents and records are kept in a good, consistent and timely fashion. We have to pay attention to what our our customers are telling us. We need to have that ear placed in hearing what our clinicians are saying. Is the lab doing the things that they want them to do, in the sense that they are producing the results and they are consistent with the patient's clinical symptoms? If they're not, it's very important to assess what the occurrence was and why is it that things are not going together with the clinical and the laboratory results. So that is very important. So those occurrences have to be taken into consideration really, really well. The assessment, we are doing audits all the time of our lab, and that is an important thing to be thinking about, how to make sure that our lab is functioning correctly. And the occurrence management and the assessment will also help us define which process we have to improve. The same, as I said, the occurrence management and the customer service is very important. And obviously, the personnel are working in facilities, and those facilities need to be safe for everybody to be working on them. So basically, you will be listening to every single lecture that you will have from here till the 10 weeks are done. We'll have a little bit of something from this thing that I have here, this little schematic that is here. So quality management system is a coordinated activities to direct and control an organization with regard to quality. And so we usually think of several agencies that are giving us the standards of what quality is, and that's the ISO, and we'll talk a little bit more about ISO and CLSI later in our presentation. So all aspects of the laboratory need to be addressed to assure quality. This basically constitutes the quality management system. So, as I said at the very beginning, the laboratory system and the quality of the laboratory includes everything, even though we sometimes think, well, the only thing that I'm looking at is the examination. That's the analysis itself. In reality, it needs to look at everything, at how the patient was prepped and how the sample was collected, the competency of the people that are taking the sample, the competency of the people that are doing the tests, how the sample is received if it's sent somewhere else. Obviously, all the quality control that goes on having our samples tested, having a record keeping that is pristine so that we have all the documentation that needs to be done. And it's not only of the results, but it's also of the maintenance of the instruments, of all the stuff that needs to happen in the equipment per se, and the safety of the laboratory, and reporting our results to the clinician. So everything is very complex, and it takes a lot of people to be looking at the different areas. So in order to be looking at the different areas, one of the things that we do a lot, particularly when I'm thinking about any of our processes, is a path of the workflow. And we want to make sure to examine every part of the workflow. And sometimes you say, well, the test selection, for example. Well, that in itself can be a whole workflow, or sample collection. We have multiple ways we can collect samples. So there could be several workflows to sample collection, several workflows for transport. Obviously, we have so many workflows for laboratory analysis. If you think, for example, in anatomic pathology, some of the stuff is stained with H&E. Some of them things are biopsies, which is a very different workflow than a workflow for a whole full breast or a colectomy. The same thing would happen for special stains. That's another complete workflow, different workflow. So each part of the whole workflow that we have here, from the patient to having the analysis, to having the report creation, every single part of it can be a workflow in itself. And you will see some workflows that, especially for sample, that we've created and that some people will be presenting during this sessions. So why is the path of workflow essential to consider in healthcare laboratories? Well, it basically looks at the entire process of managing a sample. It must be considered from the beginning to the very end, and it will have different parts in between the whole thing. I think there seems to be some raised hands or some questions. I don't know if people want to ask some questions, but I'm not sure I can see them.
Jeanette, I'll let you know if there are any questions.
Oh, okay. Thank you.
Don't use any of the other boxes. Thanks.
Okay, so I have a question for you. What is the stage in laboratory results that has consistently been the one that has the most errors? Is it the pre-analytic, analytic, or post-analytic? I'll let you think about it for a few seconds, and then we'll look at the answer. So it's basically the pre-analytic, the one that where most people have found errors. And this is interesting because I chose only 4 publications, as you can see, one from India, one from the States, one from Italy, and one from Iran, in which they look at where the different errors occur. And actually, you can see that the pre-analytical errors are usually considered like the between 53 and 77%. The analytical errors are usually the least, together with the post-analytical. Post-analytical has a little more, but not that many more in every single one of these publications. So the pre-analytical really is the one that can mess up results, particularly for the core lab, but it could also happen in anatomic pathology. So the laboratory results are influenced by the laboratory environment, the knowledge and competency of our staff, how our equipment and our reagents are performing, making sure that the quality control versus whether it's internal or external is working correctly. Also, the communication between the staff, in between, especially if there's a specimen that is in the middle of testing and one person has to leave and then the other one has to take over. Those communications are important, but also the communication between the tech and the clinician may be very important. All the process management that we've been talking about, the occurrence of management and record keeping. So all of these influence our laboratory results. So we've already gone through this little table, and you have to think about this as the 12 quality system essentials. And they are the building blocks for having a quality management that is functioning adequately. So I'm going to go through a little bit each one of the 12 essentials. And it's, as I said, it's really important to think about them. And each one of the lectures that you'll be receiving will have more on each one of these topics. So the organization, as I said, it's essential for quality because it basically delegates all the responsibilities or the authority, or gives the authority to the different people to be able to purchase things, to be able to analyze things. So it's super important to have very delineated how the organization in the lab works, but also how the organization in the system in your hospital is working. And there needs to be communication of all this organizational structure in your hospital. So the personnel, obviously when we hire somebody, it goes through human resources, and that, takes all the job qualifications, job descriptions. But then we spend a lot of time, at least here in the United States, once that has been done, and we know we have a new med tech coming, we spend a lot of time basically orienting and making sure that the tech that we've hired knows exactly what they are supposed to do. We go through they have to read all the procedures. We have a checklist in which we say, well, do they know how to embed correctly? Do they know how to cut correctly the slides? Do they know how to stain? Do they know how to cover slip? And so we go through a whole training. Even though they've been already trained, we want to make sure that they know the Emory way, okay? I work at Emory, so they need to know the Emory way. If they're in Nigeria, they need to know what your hospital way is to make sure that they know exactly where the reagents are and all that stuff. So it's super important to be cognizant that, yes, you hire somebody, but they are not going to start working immediately. They have to have some training. And then we do competency assessment in the United States. We're asked to do competency assessment when the tech is starting, and then at 6 months, and then at a year. And then from that on, they do it yearly. But we need to make sure that they maintain their skills year to year. And we not only want to have them competent in what they are doing, but we also want them to develop professionally and to have continued medical education. So there's all these things that are happening in just the personnel files, let's put it that way, and the people that we have hired in our facilities. Equipment. Well, it's very important to know, how to acquire the instruments, install the equipment, and validate the equipment. One of the things that I think can be very difficult sometimes in lower income countries is that the maintenance is not that great. And I think that's one of the biggest issues that you sometimes have with equipment. When I was working in Mexico, I always said, well, whatever instrument we're getting for the core lab or for pathology, it needs to be a vendor that has somebody that can come in a whim to help us troubleshoot a pipette or troubleshoot some of the robotic arms or any of the stuff, because we need that maintenance. We need to make sure that they are available for troubleshooting, and we want them to be in-house. If they were in India, then we would be in totally different time zones, and we wouldn't be able to communicate with them. So to me, it's super important for equipment to make sure that we have somebody in the area, in the location, the geographic location, that can give you service and repair and maintain all those records of what's going on. How long have you had this refrigerator? Is it time for the refrigerator to be changed so that it doesn't crash on you? That sort of thing. So it's always very important to think about the different components of equipment in between the acquisition to the installation, the validation, and all the way to the service, and eventually the I would call it the demise of that equipment and how we're going to dispose of it.
Jeanette.
So, yes.
This is a perfect time to demonstrate troubleshooting in real time. So what I've learned is that the bar that everyone is seeing at the top of the screen is because you're sharing your desktop, you're not sharing the application. So what I want you to do is stop sharing your screen.
Stop share, okay.
Now I want you to hit share screen, but when you have the options to share, you want to share just the PowerPoint presentation app, not your whole screen. Is that
no. Done?
No, that's still the desktop. So stop share again. Now you should see several options. One of them should be for the slideshow itself, not for your desktop. Do you see that?
Share. So I click now at the share button here.
After you hit share, there should be options up there to share your slideshow. You see the different screens you can share?
Yeah.
There's one that should just be the slideshow.
I don't think I did the right thing. Is that it now?
No, that's still not it.
Oh my God.
It's okay. No. So what you need to do is stop sharing again.
Okay.
Go minimize the Zoom so that you can see your PowerPoint software.
Minimize. I can't do that.
Okay.
Okay. So I can see it. Yeah.
Switch to PowerPoint. Now start the slideshow in PowerPoint without sharing the screen. Just start the slideshow.
Okay.
Okay, now go to Zoom and hit share screen.
Oof.
You can do Alt Tab. If you did Alt Tab, you can get back to the Zoom screen.
Okay, and what do I do now?
Now, when you hit share, you should have an option to share, and it should just be the PowerPoint presentation, not.
No, it's not letting me.
Okay, it's probably because you're on a laptop. So just go back to sharing your screen again, and we'll have to sort it out for next time.
Yep, I agree with you.
This is a good example of troubleshooting and not finding a solution, but still being able to work with what you have, and we'll move on. So go ahead.
Are you seeing the presentation now?
No, we're just seeing you. You need to share your screen again.
Okay. Oh, okay. Are you seeing it now?
Yeah, but it's not we need to see and then hit that. Yeah. Okay. Continue.
Okay, sorry, but yeah, that's some of the troubleshooting, and when you're not in the same location, sometimes that's what happens. So that's an important lesson to think about when you're thinking about troubleshooting, because we do a lot. Interestingly enough, exactly what Dan was doing with me a minute ago is something that we do a lot in the lab. We connect remotely to the vendor, and then the vendor starts working with it. But then if they see they can't fix the problem, then they have to come. So that's where I think it's important to know that you have somebody in your region that can come within 1-2 hours to fix whatever you're having as a problem. Because sometimes, even if you're trying to do it remotely, which sometimes they can do, and they can do a great job, you can't fix it. And obviously I'm not that great at fixing this, so I'm sorry. So now we're going to purchasing and inventory. You want to make sure that you have vendor qualifications. It's really important for us that whoever is our vendor complies to has a CLIA license number, which is something very US centric. Meaning, CLIA only exists in the U.S. Well, maybe they exist in other places, but it's a U.S. United States thing. But we want all when we refer samples to be tested for whatever it is, we want people to have that certification, because that allows us to be able to make sure that they are audited, and that they are in the best quality that they can be. So the vendor qualifications for us are super important, not only for the equipment, but also for all our supplies and reagents. And also we need to make sure that we have an inventory, and we, especially for certain things, we like to have sequestered lots in such a way that we don't have to be doing a lot of lot-to-lot validation on a regular basis. So having sequestered lots for us is a very important thing to sometimes have that. Process control, and this is just something, I just put a little graph there. because that's what we use in the clinical laboratory. That's our an example of a Levy-Jennings chart that I created. We do controls, internal controls for high and low values, and sometimes even normal values. But I think the most important thing is that we want to plot this results on a daily basis, and sometimes 2 or 3 times a day, and make sure they are falling within certain parameters. And we have the famous Westgard rule. So like, for example, in point A, that would violate one of the Westgard rules, because we have four measurements of that particular analyte that have been above 1 standard deviation. So the techs, when they hit this, they may be seeing a trend or something happening there. So they have to look at the reagents. They have to make sure that they haven't expired. So there's a variety of rules, and whoever is going to speak about internal quality control will be talking about this, because that's something that we use regularly in the clinical laboratory. Obviously, we also be talking about method validation and verification, because those are very important aspects of bringing new instruments or bringing new technology into your laboratory. Information management. Obviously, we have to talk about confidentiality, the requisitions, how are they coming to us? Do they have the clinical history that we expect for anatomic pathology? How long do we keep the requisitions? Where are they stored? Where do we keep our reports and all the records of quality control of our instruments and maintenance of our instruments? All those things are very important. We tend to keep a lot on computers, but they can also be kept manually. And it's perfectly fine to do so, but then you have to make sure that you're continuously updating whatever you need to update and putting them in the correct location. So obviously, all the documents, I think the policies and procedures need to be written, they need to be reviewed, need to be revised if something changes. And we have a stipulation that every 2 years, we have to make sure that they are relevant. So if something is not relevant, then we have to change it. So this is one of the things that happens or is most problematic when you have inspections or audits, that your documents are not, that your policies or procedures are not being updated on a regular basis and haven't been signed by your director. So it's very important to have all these documents ready for review by inspectors. So occurrence management, as I said at the very beginning, complaints, mistakes or problems need to be documented. You want to do both apparent or root cause analysis, because you need to investigate what's going on. You want to have actions to whatever problem has been created. So you want to make sure that there's a corrective action, and you want to also prevent from these occurrences to occur. So you need to make processes in such a way that allow you to prevent more of these complaints happening, particularly if a complaint is very recurrent. You want that to disappear, and in order to disappear, you may need to change your process. The laboratory assessment, basically what it means is the inspections, okay? So you can have an internal audit, or you can have an external audit. And so, in the internal audit, usually you want to make sure that you want to review another area that is not yours, because then somebody with different eyes looks at that area and says, oh, okay, so the gross room reviews histology, histology reviews the gross room. And so you have a better idea, okay, this is what's happening here, this is what's happening there. And then you can even learn a lot by doing that kind of auditing. And in the external, you have the proficiency testing and obviously inspections by an accreditation body that could give you the ISO accreditation or other that you may want, your institution may want to have. So all the process improvements are opportunities. They are something that will allow you to go from being at the bottom to go up and scale and to get better quality for your patients and for your results. So as I said, you need to make sure that you have these actions that are corrective and preventive so that you can improve whatever you are doing. And it doesn't have to be a complete jump. You don't just create a process improvement, and they'll talk about that, and I'll talk a little bit about that too. You sometimes have to do it on steps. You cannot all of a sudden create all the policies that you need or procedures that you need. Sometimes you have to nib at the cake little by little. You cannot just do the entire cake because then you will get a stomach ache. So you have to go little by little nibbling at this big thing that is quality in your laboratory. Customer service, you need to identify who your customers are and what the needs of your customers are. And we know that even though our ultimate customer is going to be the patient, in reality, a lot of who our customers are physicians. I think of the physicians as being the very learned people that can give you better input on what I'm doing. And so to me, it is very important to make sure that the physicians that are using the lab are the ones that are telling me how they think the lab is doing. So the facilities and safety, it's very important to make sure that your workers are in a work environment that's safe, that you're managing the waste. You don't want people to start, having problems with their backs or anything like that. You want them to work in such a way that they are working comfortable and that they can do the work. If you have pipettes and then they end up with strain in their hands and then they cannot pipette anymore, then they're not good techs anymore. So it's so important to have ergonomics included in your safety. The same thing for the entire laboratory, the security of your areas and how you manage all your safety. And if there's a fire or if there's a spill, how do you manage all that stuff? So as you will see through the entire weeks, and you have here the entire 10 weeks, we're basically going to be talking about all the things that I just delineated really, really fast. We're going to do a deep dive, and there's going to be different people talking about the different areas and in much more in detail. This was just like a little, very, very, very high view of what we're going to be looking at for the entire course. And I hope you enjoy having the interaction with all these wonderful people from the United States that can help you with this quality management. So implementing a quality management does not guarantee an error-free laboratory, but it detects errors that may occur, and hopefully it prevents them from being a recurrent problem. So laboratories not implementing a quality system guarantees that you're not going to detect those errors. So the most important thing, as far as I'm concerned, I'm happy when people say something to me, because then I know, well, okay, people are paying attention. So I don't want to have tons and tons of these occurrences. However, when there's something that's not working right, I want to know. I want the people, whether it's a lab tech or a physician, I want them to tell me, I don't think this is working right. And then I can dig into it. I can find out what the problem is. So if people don't care, then things don't get detected. And then, then why do the job that you're doing? So I think this is a good point for us to stop and see if there's any questions, and then we'll go into the case.
Thanks, Jeanette. We have quite a few questions which we're answering within the chat. So I think I'm just looking to see if there's any that we should answer live. So could you explain the difference between semi-quantitative and quantitative method validation?
So when the time comes and whoever talks about a process control, especially the qualitative and semi-quantitative, when you say qualitative, it's usually a plus minus, yes, no answer. Like, for example, is the VDRL positive or negative? Okay, either positive or negative. There's no in between. It's either positive or negative. As far as I know, there's no borderline VDRLs. So, but a semi-quantitative would be maybe the dilution or the titration that we do, where, okay, you found that it was positive. Now you're going to titrate to define, how high that VDRL is. You can do it also, for example, with in anatomic pathology. You can say, well, you have HER2 for breast cancer. So it's positive or it's negative. If it's negative, well, it's done. But then if it's positive, then you have to say, is it a 1+, a 2+, or a 3+? So those are the things that we think about for semi-quantitative. And obviously the quantitative would be just the glucose number. Okay, my glucose is 182. Hopefully not. Hopefully it's 100. But that's the type of thing that we're looking at. So when you get a total number that you have a number, then you have a number. Now, when you go through the quantitative QC, we'll talk about the coefficient of variation. So we know that 182 is not necessarily 182. It could be 181, or it could be 180, because there's some variability if you measure continuously or several times that glucose. There could be a little variability. So those are the quantitative. Semi-quantitative is the 2+, 3+, maybe some titrations. And then the qualitative, the purely qualitative, is it positive or negative? Okay, did that answer the question?
I think so, yes. Thanks, Jeanette. And then I have one more, a couple more. So how is sequestered lot verification performed, given we, meaning labs in Africa, usually have a single lot at a time in our labs? Is this cost effective?
Well, let me tell you why we use sequestering. So I'm going to put to me, the best example is the coagulation testing, particularly the PT, the percent time. Because in order to be able to do your INR, you need to have a number that the company gives you, which is called the ISI. You need to have your normal controls, which is your mean that you're going to have the patient's PT over the mean of normal people, and then you're going to multiply, or you're going to put that to the ISI that the company gives you. If each lot of PT, it contains something that's called tissue factor. So some tissue factors are very linear, while other tissue factors are not that linear. And so the issue here is every time you get a new lot, you get a different ISI, and then you have to change your geomean, you have to change your ISI in your calculation for your INR. So we're a big enough system at Emory. We have 7 hospitals, and we obviously consume a fair number of PT reagent. So the company we buy from, our PT reagent, our tissue factor, we ask them to keep in their store the lot that they're giving us, for our system, so that we are not constantly every month having to change that calculation. So that's how we function with the sequestering. But I guess it's a very, we do it a lot, and the companies do comply, but they usually comply because we are buying a ton of reagents from them. I don't know if
no, that's, yeah, thanks, Jeanette. And I think there's a couple more. So should a QMS policy/quality manual be created before any other documents before starting the QMS implementation?
Oh, that's an interesting question. I consider the QMS manual an evolving document. To tell you the truth, all our procedure manuals are always evolving. I think you have to start with a framework where you say, okay, these are the policies and the procedures we are going to do for personnel. Okay, and these are all the policies and procedures that we're going to do for equipment. And then as you evolve with in your step process to do the management system, you're going to be changing these procedures because you're going to be evolving. I don't think I think the procedures and the manuals are living documents that I don't want to modify them every day, but if there's a need, you modify. So I think you should start with a framework. And then once you have a framework, then you start digging into each one, either separately or, with more than two people working on them. But I don't necessarily think that, there's different ways of eating a cake. You can try to buy the big bite, or you can try to do a smaller one. You usually want to start by the end instead of, by the side, rather than biting in the middle. So, you put a framework, and then you start working on things as they are important to you, and as you see fit, they need to be done. Hopefully this helps.
Thanks, Jeanette. And then our last question, I think we can move on, which is a really very appropriate one. I think it's a really good one. So in pre-analytical phase, the issue of completely filling in of lab requisition forms, most clinicians find it difficult to extract the date of birth from caregivers in case of children patients, and they leave it blank. So what advice can you give the lab to clinicians on the methods they can use to get that vital information in the case the caregivers can't remember the date of birth or are illiterate?
That's a great question, and I guess you can, especially in children. I don't know if you could do a weight and height in such a way that you could gauge in more or less a time where they could be in their growth curve. Although obviously, if you have malnourishment, then that's going to be problematic. But I think that may be a substitute, but I'm not sure. That's a great question. I never thought of it before. I guess we have good records in Mexico and other places I've been where that has not been an issue. The other thing is, I don't know. What do you think, Dan? That's a great question.
I mean, I think that we have to consider that what are the identifiers that we can use for that patient that will be consistent. If we don't have an electronic medical record, but the patient has a medical health passbook or a medical passport, or the hospital has patient-specific numbers that they issue that are written on all the paper charts, that can be a fix for this problem, is that a patient is given either that number or you write all the information in their medical passbook. I think for small children, especially that may not have, that have a parent or guardian, but may not have a place to have things like an ID card or that sort of stuff, it can be quite challenging. There are some biometric approaches that you can take with pan prints, footprints, or fingerprints, but in small children that can also be difficult. So I think the best way that I've seen, at least in the work I've done directly, was the medical passbook or the health passbook, where the parent keeps it with that particular child, and therefore at least the results can be written down. It does require a lot of legwork in order to get the lab result back into that passbook, but because the parent has that as their responsibility, they seek out the answers to put them in there. But how to keep them in the system, especially an electric system, is extremely challenging. So I think it gets to the point where if you're going to use an electronic medical record or a laboratory information system for your lab testing, you need to come up with a patient number assignment or way to assign patients a number, and that number needs to be given to the patient so that results can be found.
So I was thinking, like for example, in Paraguay, one of the things that they do is they have an identification that's given to the kid when they are born. And I think that's a little bit like the Social Security that we have in the States, that you get a Social Security number, but we only give it in the States once the parents ask for it. So if a parent doesn't ask for it in 2 years after birth, it won't occur until then. So it's interesting. That's an interesting question. But there's some countries that they give an identification number to people as soon as they're born.
I think that's all the questions, and I think we can move on. Go ahead to your scenario.
Okay, so the scenario I have for you has to do more with culture, okay? Because I think that one of the biggest issues that we have to think when we're thinking about quality is about the culture that you have in your hospital. So I'm going to read it to you and then give you some time to think a little bit about it, and then we'll talk about, what's the culture and what do you think about it. So you get a call from a dermatologist that sent you a sample from a patient. She complains that your report states that the sample from the right arm was a melanoma, but in her note, she says that the melanoma is on the left. Then your report states that the sample from the left arm was a nevus, while she noted that the nevus was in the right. In other words, this dermatologist took 2 biopsies, one from the right and one from the left. She thinks that the melanoma is on the left, but your report says it's on the right, and the nevus is on the other. It's the reverse. So what's your gut right now? What does your gut tell you? What do you think? What do you think we need to check? What will you do? So I think one of the biggest problems that we have with a scenario like this is that we have 2 different departments. We have dermatology and we have pathology. And the process, it goes from the analytical, from the pre-analytical all the way to the analytical and the post-analytical. So if you think about it, there can be issues through the entire system in which you can, or the entire workflow, where something could have been switched, where left could be labeled right, or the left could be labeled, the right could be labeled left, and the left could be labeled right. So I think one of the biggest issues is when you think about this, what's happening? It's not advancing.
Use your arrows, Jeanette.
I am using them. I don't know what happened.
Did you click off of the?
Oh, there we are. Yeah. So in the scenario, me, pathology, is sure that the error occurred outside my area. Okay. And I think that's the typical thing. It's like, I am not to be blamed. The one that it needs to be blamed is the dermatologist, because that's clearly where most of the errors occur. We know that they're usually pre-analytic. So they are the ones that did the problem. They are the ones that mixed up the specimen, okay? However, the dermatologist thinks that the error was the laboratory, okay? So obviously she has a problem in her hands because she needs to do a bigger resection on the side of the melanoma, but nobody knows which one is the melanoma. Is she going to do a bigger resection in both, or what's she going to do? What is going to trump the other? And I think the biggest thing here is to stop playing the blame game. We should not be saying, oh, the dermatologist is the one that did the problem, or the tech is the one that did the problem, or, oh, the cassettes were switched, or the most important thing here is to review the entire process, review the entire workflow, make sure that you go step by step. You know, as we say, do a root cause analysis where you are going to be looking at each one of the steps where you can have this mislabel, and make sure that you have a correct process so that the issue can be corrected. In other words, you know, we have to change our attitude on blaming people. We cannot continue, we cannot improve a process if the process is going to be, I blame somebody. The only way to improve a process is to improve the process. Okay, you cannot just say, this is the person that, and we fire that person. Unless they do it recklessly and they did it on purpose, you can't do that. You have to think about what we call a fair and just culture. You have to decrease confrontational attitudes and be a team to review the entire process and see, okay, so how did they label the containers when they took them? Did they take the biopsy and put it somewhere, and then they put the two biopsies together, and then they didn't know which biopsy was which when they obtained the biopsies? Did they put them, the right in the right and the left in the left, so that they could put them in the correct container that is labeled correctly? Now, in our hands, we can switch so many times containers, because if you have two containers opened and they label the lid, then you're off to have a problem. And you only want to open one container at a time. So you need to make sure that the entire process is pristine in such a way that you avoid the possibility of either at the dermatologist or at the pathologist side to create that mistake. So a fundamental concept in an inequality system is that the person is not at fault, okay? Pointing fingers is not what we should be doing. That should totally be, we should totally get away from pointing fingers. What we need to do is we need to look at the process, because usually what is happening is there's a defective process. And in order to correct that error from occurring again, is to workflow your entire process from the dermatology all the way to the report from the pathologist, and see where are the places where that switch could happen, and make sure that you put guardrails as to always take the sample from the right labeled right, and always take the sample from the left labeled left, and to maintain the integrity of that process through the entire analytical, through the entire cutting the specimen, aliquoting it, as we say it, because we're basically cutting little pieces. So we're aliquoting that skin biopsy all the way to having the report of our patient. I don't know. Well, here, another thing that is very important to think about is that usually when an error occurs, there there are multiple critical points through the entire system. And we always talk about the Swiss cheese, where there's a risk at this point, but if all the stars align, you may end up, or all the holes align in the Swiss cheese, you end up with an error. So the most important thing to think about when you're thinking about a quality system is to establish a fair and just culture. A fair and just culture means that you want people to be treated fairly, because people go into medicine or to technology in the labs because they want to help people. They don't go into the professions that we have because they want to hurt people. We want to help people. So nobody's here to do harm. We're here to help patients and to help the physicians do the right thing. So if we think about that all the time, yes, we had an error. This error needs to be corrected. Let's look at the process. Let's plan, workflow the entire process, make sure that we have all the guardrails so that we decrease as many risks as we can through the entire operation. So obviously, having exceptional behavior is going up and above expectations, and we want to recognize these people. We want to say kudos because you recognized an error, and you want to have people to say, okay, you recognize that there was an error, or you recognize that there could have been an error, and you, what we call a near miss. So if somebody finds that there could be an error and they prevent it, those people need to be recognized. Kudos, great for you to having found that potential error, and good for you for pointing it out so that it doesn't happen again. Then the human error, making honest mistakes, having a slip or a lapse, you want to support, you don't want people to feel guilty that they committed an error. You want to support them. They're good workers. They are not doing this on purpose. So you want to support them. People, if they are doing things that are risky, okay, they're violating procedures and they are taking risks that they should not be taking, then you train and you coach. And then obviously there are the people that are reckless, that are taking shortcuts, that are doing things for their own gain. Those people need to be disciplined. So as you can see from this thing that I have here, the schematic that I have here, I think when we're talking about a fair and just culture, we need to always be thinking about, the procedure, the workflow, how to, look at every single step, and making sure that you have a process that sometimes it's impossible to be completely fail-safe, but the most you can to have a fail-safe procedure, and in such a way that at every step of the way, you decrease the risks as much as you can. And then obviously, if people are not following procedure, well, then there's just a different story. But if people are following procedure and you find a different hole, go and find how you can decrease or minimize that particular hole in that procedure. And that goes a little bit to one of the questions that we were talking about before. You're going to start creating procedures, and sometimes you're like, okay, you start by one procedure and you don't realize that there are holes in that procedure, and then all of a sudden, I didn't realize there was a hole in this procedure. Let's write this up so that people know what to do, so that they don't have another problem like this. So the procedures should be living documents, and we should be revising them continuously, and we should be thinking about the workflow and trying to make sure that the procedures are easy to follow, and that they decrease the risk to our patients. I don't know. I think I have here some fun things to think about. So I like to put things on stamps. in my presentations. So, and each one of these has a problem. Each one of these stamps has a problem. Obviously, this one, they put the little holes where you cut the stamp not in the right place. This one here, obviously, they had two different rows of where you can cut the stamps. Here, obviously, they forgot to put the train, which is quite obvious. However, this three here, or this four here, are quite interesting, in the sense that you really need to know to be able to detect the error. The one here in the center is quite interesting because you can see the flag is going on one direction while the fumes of the train are going in another. So obviously, whoever did this stamp did not pay attention to how the wind blows, because if the flag is coming this way, the fumes of that train should be going in a similar direction, although a little different maybe, but quite similar to the one that the flag is moving. The one here with Robert Schumann is interesting because what they fail to do is that the score that's behind Robert Schumann is actually a score by somebody else. It's not a score by Schumann. So unless you're a music lover, you will not know what score is behind. And this one I love because this is President Roosevelt, who loved to do stamps. And the most interesting thing is that if you look at his left hand, and you count the number of fingers, he obviously has his thumb taking the stamp on one side, but then you count 1, 2, 3, 4, 5 fingers. So he had 6 fingers. So, errors occur in many different ways, and it's fun to sometimes look at stamps or look at things, and some of these stamps can be extremely valuable because of the fact that they have errors. I don't know if there's any comments regarding the case and a little bit about the stamps, maybe.
We don't have any questions right now, Jeanette. If people want to ask questions about the case with the melanoma on the wrong side, or about the stamps errors or other comments, please put those in the Q&A now. Otherwise, we will move on.
Okay.
I think we can move on. Yeah, we don't.
Okay,
go ahead.
Cool. So we're going to talk a little bit about the history of quality. And to me, really interesting that the history of quality starts in industry. It doesn't really start with labs. And actually, it's funny to think about how industry has impacted in our life in the lab. So the first person to think about is this gentleman called Walter Schuhart. Actually, he worked for Bell Telephone. And one of the things that he did is he actually started using run charts. Okay, so you think about our Levy-Jennings charts where we plot our internal QC for high, low, medium glucose, our run charts. And he's the first one to start doing the run charts. The other thing that he started doing is something that people are going to be talking about when they talk about process improvement. They'll talk about the plan, do, check, and act, the PDSA. So he also, whenever he saw that there was something that was not in the realm of the run chart that he was monitoring, he started doing, okay, so I have a problem here. What do I have to do to make it work? Then he would do a change, then he would check again, and then see if it had corrected the mistake or the error, and then kept on doing this plan, do, check, and act, PDSAs as a way of doing process improvement. The next one is Edward Deming, and he, interestingly enough, was a mathematician that worked for the US Census. He wanted to increase productivity using the previous gentleman's methods. Okay, his philosophy was cooperation and continual improvement, avoid blame, defines mistakes as opportunities for improvement. Again, my case was about avoiding blame. I think that's if you get anything out of this, the introduction, and you take home avoiding blame, I'd be very, very happy. The next one is Joseph F. Juran. He was an engineer, and he described the Pareto principle. And this is an interesting thing. There's even something called the Pareto chart, in which you take, you do the observations, and then you see how many mistakes are due to the different components of that particular situation and or event. And then you say, well, not having the chart in the room produces more mistakes than not having a thermometer in the room. I'm just putting an example. So if you correct not having the chart, you're going to basically take care of 90% or 80% of your errors. So that's the beauty about the Pareto chart, that it allows you to say, okay, if I take care of the first three things that are in this particular, error thing that we're looking at, if I correct the first three, I will take care of 90% of the errors that occur. So it's a very potent and a very important way to prioritize how to where to put the money, where to prioritize your efforts to start doing different process improvements. So I think this is a very very important thing to remember. The other thing that he talked a lot was about the cost of poor quality. He spent a lot of time talking about, having poor quality costs in lives, costs in more material, costs in doing repeat testing, costs in many, many things. So it's very important to think that quality is something important, because it basically gives value. And then Phil Crosby worked in the Navy. He had an emphasis on prevention. He devised 14 steps, which include management commitment. We talked about the organization and making sure that the organization is committed to helping you improve quality. Having a quality improvement team. So this is not a thing that is done by one person. Obviously, you can have a leader of your quality management, but it's not done by one person. It's done by everybody in the team. You want to continue to measure everything, because that's how we define if there's an error happening, how to remove errors, and having a requirement of quality, a statement that says we are committed to having the best quality for our results. Now I have a question for you. Where did the Six Sigma concept originate? Okay, so we talked about the Six Sigma when we talked about the errors and the frequency of errors and the Orly airport. So where did the concept Six Sigma originate? In Ford, in Toyota, in Motorola, or Samsung? So it originated in Motorola, and there were two people that were basically Bill Smith was the inventor of the Six Sigma. He's the guy. He's the guy further on the right. Robert Gavin was the executive officer, so he took all the glory of doing this. But the one that invented it was Bill Smith. And basically, what you want is to have the closest that you can be to the Six Sigma. But I would say that even operating at the 4 or 5 Sigma is pretty good. Obviously, having a Six Sigma is just absolutely great, doing a great job. So we talked everything about the 12 components. However, there's what they call the 6 C's for a total quality management. You have to have commitment, We talked about culture. We have to have continuous improvement. You have to have a cooperation of your team. You have to be customer focused, and you have to have control of the stuff that you are doing. So those are the 6 C's of the total quality management system. So we're going to talk now about ISO, and these are some stamps regarding ISO. So ISO is something that is not only for laboratories, okay? So it's the International Organization of Standardization, okay? And they regulate a lot of different things, okay? They regulate from buildings, schools, they regulate a lot of different, or I don't want to say regulate, they have standards for almost everything. So the laboratory quality management system is a coordinated activities to direct and control an organization with regard to quality. And in ISO, basically the ISO rules or standards are the 9000 and the 2000. So there's 2 organizations, the ISO, okay, or the CLSI. I already told you what ISO means. Now, CLSI is Clinical and Laboratory Standards Institute. It was formerly known as NACLS. The ISO is a guidance for quality in manufacturing and service industry. It has broad applicability, is used for many kinds of organizations, as I said, from schools to beverages to everything, and uses a consensus process in developing standards. The CLSI are guidelines and standards that are best practices for quality in medical laboratory testing. So these are specific for the laboratory. They're detailed. It applies to medical laboratories specifically, and it uses also a consensus process in developing the standards. So the ISO documents in the laboratory is the 9001 and the 2000 quality management requirements. They're models for QA in design, development, production, installation, and servicing. Then the ISO and the European Community 1725 are general requirements for competence of testing and calibration of laboratories. And then the ISO 15189 is a quality management in the clinical laboratory. So you can see they all have different names. There's the different, not names, the different numbers, because, you know, as the standards are created, they're giving different numbers. So let's go a little bit with the last one, which is the 15189, is the Foundation of International Medical Laboratory Quality Management. It's for medical laboratories, and it has particular requirements for quality and competence. The CLSI documents, again, they have letters and numbers. The HS1A2 is a quality management system model for healthcare. It describes quality system models in 12 essentials that we've been talking about. Tell me that you don't know them, because we've been talking about that all day today. It aligns with the ISO standards and parallels the industry standards, and it applies to healthcare systems. Now, the CLSI GP 26A3 is an application of quality management system model for laboratory services. It describes laboratory application of quality system, relates to path of workflow, and we've been talking about workflows, the quality of system essentials, assess the laboratory in improving processes, and it's related to the ISO 15189. So as you can see, these documents are play on each other. They are not, they are talking about the same things in some way or another. Now, the World Health Organization has done something quite interesting, because they've realized that for certain countries, and it's not privative to Africa, it happens in some countries in Asia, it happens in some countries in Latin America. It's impossible to get from, I've been putting the example of a cake. You're not going to eat the whole cake in one day, because you're going to end up with a stomach ache. So what they've done is they've talked about nibbling at that cake. And, you start by step one and you get a star one. Then you progress in your standards. You have better processes. You have written and documented process improvements. You get a star, 2 stars, and so on and so forth, until you get to be to have a star 5 stars. Obviously, the WHO is very interested in having the national and regional laboratories having 5 stars, but it doesn't mean that only them can get them. If you work enough and you do the right things, even a local lab, a private lab maybe, can start going up the different stars of the WHO and get into having an accreditation. But it's a stepwise process. It's not doing everything in one sweep. Okay, so I hope that today we've gone over the quality management. You probably understand that it's not new. It's been in industry for a while, and it's been going on for a while, even in many laboratories. It grew from good works of innovators that have spanned many decades. The management is applicable for the medical laboratory, and as it has been for manufacturing. Okay, the laboratory is a complex system, and all aspects must function properly to achieve quality. So you want to approach the implementation looking at your situation, and that's why when they ask me the question, where do we start? Well, it depends on your circumstances. You just need to decide, we're going to start with personnel maybe, or you want to start with quality improvement, or so each laboratory will start where they feel is fitting for their situation. They say here that it's easy to start with the easiest, obviously, and that's good, because then if you start with the easiest, then you see that it can be done, and then you move up. Because if you start with the most difficult one of all the problems or of all the procedures that you have, then maybe it becomes such a daunting task that you will never be able to achieve it. So it's always good to start with something that's easy and it's doable. And ultimately, once you start doing this, all the elements will be addressed, and you will have a good, quality management system. So I don't know if there's questions or comments.
Yes, thanks so much, Jeanette. And I think just a couple of clarifying comments, and then I think I have some questions for you. So first, there are many of you who are commenting that the lecture appears to be presented in the ISO 15189-2007 language nomenclature. I apologize for that if that's the impression you get. We will be using the ISO 15189-2012 nomenclature throughout this series. So if there were some comments or things that Jeanette said that you might have thought were from 2007, apologies for that, but all future lectures, I can assure you, will be in the 2012 nomenclature, so don't worry about that going forward. A second comment was just the definition of Six Sigma, and so I just want to give you just very briefly an understanding, because there are 2 different ways that standard deviation, or also known as sigma, are used in these lectures, and I want you to be very clear on them. So when we talk about not making an error, what we say is that we want to perform so well that we only have an error occurrence less than 6 sigma, meaning less than 3.4 errors in a million, because 3.4 errors in 1 million is at the 6 standard deviations outside of the norm. So that's why we say 6 sigma or 6 standard deviations. It's just a really rare occurrence for us to have an error if the laboratory is functioning properly. So that's what we refer to when we say 6 sigma. But when we're talking about, for example, process control charts, we may show 1 sigma or 1 standard deviation, et cetera. That's actually just talking about how accurate our values are and that they oscillate around the mean. They may go up to 1 standard deviation or 2 standard deviations away, et cetera. But that's in the context of the mean value for that test that we expect to get. So that's where you also see sigma or standard deviation used, but it's a separate concept. The first concept that Jeanette mentioned is really about not making an error and reducing as many errors as possible. And the phraseology is 6 sigma because 6 sigma is 3.4 errors in a million, which is what we're shooting for, that or less, okay? And then the other comment I wanted to clarify before we move to a question was, there's a question now for Jeanette. So in the avoiding blame theory, who takes up responsibilities for errors or mistakes? Does it shift responsibility to the lab manager? So Jeanette, if you can answer that one.
Well, I think it shifts the responsibility to the lab director. The ultimate responsible is the director. But again, I wouldn't want to say that person is to be blamed. I think what you need to think about is this, there's an error. You acknowledge that there's an error, that the lab made an error, and you're the representative because you're the lab director. However, you want to take care of that error. And that's why you do what you need to do. But yes, in some way or another, the ultimate responsible is the lab director, more even than a quality manager person. So to me, whenever I'm the lab director of one of the labs in the hospital here, and if there's an error, I don't point the finger to one of my techs. I take the blame.
And yeah, and let me just add a comment to that, because I think it's an important issue that many of the people on this session are probably lab managers. And so we want to be very clear, although many of you are laboratorians, want to be very conscious of that and just express it in this way, which I think might be helpful. If you, as the lab manager, are in charge of, with the quality person, are working on a process, let's say a process for performing a lab test, and you write a protocol and you train all of your laboratorians how to use that protocol, and they demonstrate through competency that they can actually do that testing, right? So your expectation is that they should not make errors because you've created what we would call an, in quotes, perfect process. But they're human beings. They have a bad day. They may have something in their eye. They may have an illness that makes them not feel well. They may drop something, right? So they may make an error, and we fully expect for humans to make errors. But when they do make an error and you detect it and you work with them, you involve them in the process and you determine what was the root cause of that error. And if you determine that it was, this was just a random human error because this person was having a bad day or whatever, then the process is okay, and you make sure they're okay, that they know it wasn't their fault. It was just that everyone makes mistakes every once in a while, and that the system still works and you can move on. But if you have an error and you go through a root cause analysis and you determine that the language you used in the process, or when you did the training, you said something that was misunderstood, you can now capture that and correct it. And so you fix the problem, and the next person won't make that error. And both of those are the responsibility of the lab director. But most importantly, if you have a laboratorian who's trying to sabotage the lab, is deliberately underperforming, is deliberately doing things in order to disrupt the operation of the lab, that is 100% the responsibility of the lab director to not only figure out who that person is and why they're doing these things, but determine a disciplinary or removal cause of action, because you are ultimately in charge of the lab. So the short answer to the question is yes, the lab director is responsible for executing the QMS system and finding errors, et cetera, but it's not in a it's not in a negative way. It's 3 components I just described: helping people understand human errors are okay and how to avoid them, making sure your processes are in place so that errors don't occur, but also being a personnel manager and responsible for finding someone who is not really a team player and taking care of them when you need to. And there will be a whole module on personnel that will deal with that. Let's see if there's some more questions, Jeanette. Hold on one second. Are there any guidelines apart from CLSI that can help a laboratory develop their policies and standard operating procedures? If yes, which ones are those, especially the management requirements?
So there will be a whole lecture on that. And I think you need to, there's a very detailed standard of how you want to, or how you construct your procedure. It has to have certain elements that are very required in every one of the procedures and policies. So you'll see that in very detailed when we talk about documents.
Great. And then just as a follow-up to what I think I was just saying, if one of the lab staff does not follow LQMS, how can the lab manager eliminate him/her from the lab LQMS structure?
Well, I think at least in the States, it's, and I think it depends on the country, because if you have a person that's in, if you have syndicates or unions, then it may be a totally different game. However, I worked in Mexico where we had a union for lab techs, and when I had to do this, which is not a pleasant thing to do, you have to document, make sure that you document the errors and what they're doing and how this is impacting patient care. So you need to make sure that you document, you need to make sure that you document that you talk to them, you need to make sure that you've counseled them, that you've done a plan for them to improve. And then if the conduct continues, you continue to document and you continue to show. And then after X number of times that this happens and you see that there's reckless behavior, then you're allowed to send the person out. So, but obviously each country, obviously each place is different, and there's laboral, I guess that's a work laws that you have to deal with when you're in the different locations, and obviously unions are a different game. So yes, it's painful, but the most important thing is document. And document how the behavior is not being productive, and it's actually causing damage to patients or damage to property. Make sure that you have a plan to make sure that the person can be trained, or at least try to train them. And then if the behavior continues, keep on documenting until you have enough proof that they say, yes, the person can go.
And there's a second question about Six Sigma, basically saying, how is Six Sigma applied to the lab? And just to reiterate what I was saying, Six Sigma is really a concept or a system to reduce errors, right? And QMS, as an example, is a system that, when put in place and executed to the best of its ability, can reduce errors greatly, and hopefully reduce them below Six Sigma, below 3.4 errors per million. So we don't use it on a day-to-day basis in the laboratory. It's really a culture concept that we're shooting for, to achieve in the laboratory by implementing a QMS system that works. What we use every day in the laboratory are standard deviation of lab values, which is, is kind of unrelated. I just wanted to make sure that it was clear that those are two different concepts, right? Six Sigma is kind of an overall concept, and standard deviation of a lab value is really how you figure out if there's an error. Jeanette, if you want to continue commenting on that, go ahead.
Yes, I want to make a comment. So like, for example, when you are buying an instrument, one of the things that you can ask the companies is to give you where they are in the Sigma range. And because that will tell you how well that particular instrument is behaving. Now, the companies usually tend to give you, beautiful Sigmas because they're testing their instruments in their environment, which is not the lab environment with techs, but with people that are specialized in that particular instrument that they know, and they are only using controls. They're not using samples. But they can tell you, we tested, 1,000,000 times this particular glucose, and our error rate is in the Six Sigma, or we've tested 1,000,000 times this enzyme, and this enzyme works at a 3 sigma level. So they do tell you what the sigma level of the different assays in their instrument are. And actually, I think if you go to the Westgard webpage, he has published the son, not the father, the son has published a whole thing on 6 sigma for different instrumentation. So it's really interesting because even though we don't, as Dan said, we don't apply it to the everyday life in the lab, you can look at the specifications of the different instruments, and they will tell you what the sigma level is for them, or you can find the sigma level based on what others have done. So that's an interesting concept to be thinking about.
Thanks so much, Jeanette. I think we don't have any other questions. So if we want to, we can give everybody back about 23 minutes today. Just a couple of housekeeping things. For those of you who are on today, we had about 185 people. We had over 600 people register. So my fear is that people did not see these invites because of their junk or spam mail. So if you are on today and you know from someone that you work with that they were supposed to be here, they weren't here, please have them look in their spam folder or their junk folder, because that is definitely a possibility of where this went. I unfortunately have no control over your spam or junk filters, but we did send out both an introductory course email, which had the landing page link, as well as we sent a registration email 24 hours ago for this session. Now, the important thing to remember is that you can register for each session about 48 hours before it opens just by going to that landing page, which was in the first email. That landing page is always active. And after the sessions are completed, that link that you use to register will actually convert to the actual recording of the lecture for that session. So anyone who misses them can always go and get those if they need to. Someone just asked, can someone register for the first time as in now? So we actually had everybody register or send us their emails to register, and we send out specifically those registration emails to you because the course is capped at about 600 people. And so obviously we don't have 600 people in the room today. We only have about 180 of you. And my fear again is with that spam or junk filter. So those people who have already registered, we want to get them in the room, but we can't have any future registrants at this point. We just need the people who originally signed up for the course who are getting that email to respond to it. Let's just see. There's some other questions. I'm going to go to those in just a second. Other housekeeping. So when you get the registration email for each time or 48 hours before, that will give you the case if there's going to be a case discussed. So for example, Jeanette's example of the melanomas on each side was in the email that we sent you to register. So the cases will be attached to those emails. So even if you go to the landing page to register, you will need to go find the registration link because it will have the case for that session if it's there. Please use your email to set your junk and spam filters to accept emails from either dan.milner@ascp.org or from globalhealth@ascp.org. You could have received it from either of those. And we will be sending those, as I said, about 48 hours before each session. A couple of questions. Let's see. Is there a component of this training that will tackle how to handle team members that are reluctant to take on assigned duties in quality management where a system is already in place? Yes, Chalia, there is a session on personnel, and personnel that will cover handling personnel, understanding how to deal with personnel, and working through that. So that session is coming up. And there's also a question, during the process of accreditation, is it okay to consider a lab accredited if only one test were accredited? That's an interesting question. I think, Jeanette, do you have a comment about that?
Well, it all depends on the test, but yes, it may require accreditation. Well, if it's a point of care test here in the US, we don't necessarily consider that accreditation. You need to have a certification, but you don't necessarily need to have accreditation because it's point of care. So it all depends on the complexity of the test in the United States, and we were very regulated. So that's an interesting question. And one of the things that I think is very interesting that Tim Amukela will hopefully talk about is the laboratories that do many tests tend to be the ones that have better quality. Those laboratories that do only one test tend to be of lesser quality. So he has done a lot of work on, in particular in Uganda, but he's done a lot of work around the world. And that's one of the things that if the more tests you do, the better you become in quality.
Exactly. Thanks so much, Jeanette. And I think that that is a good place to end this week. Again, thanks everyone so much for joining us. We will have our next session is on Thursday. You should be receiving an email within the next hour to register for that session. Remember, you do need to go in. You need to go into to register, but you can do it from the landing page, and that will give you the link that will specifically open up that session for the webinar. And you will also receive in that email the case for the next session on Thursday. There's two more questions. Will we have international QC within the sessions? I believe some of the cases will deal with examples of international QC. And then do we get to receive the study slides? I'm not sure what you mean by that. The recordings are available after the session, and you can view those at any time. And the cases will be sent to you with the email for the registration 48 hours before the next case. So I think with that, we're going to close it out. Again, thanks so much for attending, and we will see you on Thursday. So Jeanette, you can just close the webinar.
And
yeah, thank you.